This has really been a day for reflection, celebration, renewed energy, and some analysis as well. So I really do look forward to speaking with you about the education agenda from the Institute of Medicine in 2004, really till today, so a bit of a reflection. I just wanted to remind people of the five clearly articulated goals or recommendations that were offered in the report of 2004. I put a check mark next to where we have some really strong illustrative examples. For example, integrating health literacy with literacy skills, and this was done in the health literacy study circles. It was actually Mayor Bloomberg's health literacy initiative in New York, so our tools and materials were tested out and then widely disseminated throughout the United States. This was in the adult education sector, not in the K through 12 sector. Recommendations and progress in regard to demonstration projects, delineating specific feasible and effective actions, doesn't quite have a very strong check mark because the vision was much larger than what actually happened. There was not a regular effort in every single state. There was not a regular effort and partnership done with the agencies for funding. So this fell a little bit by the wayside. That's not to say that there have not been incredibly interesting and exploratory work and really wonderful demonstration projects, but it didn't have the impact on a national level that I think the recommendation was really trying to speak to. Nor did the partnership work with the National Science Foundation. This was rather sad in paying attention to this, but health literacy and the National Science Foundation did not forge the kind of partnership that we had originally envisioned. Yet the idea is still there, the goal is worthwhile, and it's certainly a worthy effort, but here too, there's not very much to report on with progress, and sadly, we see the sad effects of that lack of partnership. In some ways, global climate change is a health literacy failure. In some ways, the panic over Ebola is a health literacy failure. And had we had these strong partnerships, perhaps we would not have seen some of the failures that came about. However, recommendation 5.6, bringing health literacy into professional schools and professional education, does get a very good check mark. Again, not widespread. The work has been somewhat limited. The formal education of health literacy courses has really expanded from the first course at Harvard, continuing on where you're now seeing courses that people take for granted at schools of public health, in medical schools, the beginning of work in dental schools, in pharmacy schools. So that is indeed moving along. Sadly, however, we also face some barriers along those ways. Some of those barriers have to do with schools sort of saying, my goodness, we don't have room for something else, for something more. And one of the advice, pieces of advice that were given to several of us who were serving with the American Dental Association is that perhaps it's not going to be feasible to bring courses to dental schools unless we have something on licensing examinations. People in medicine have said something very similar as well. However, the non-formal education sector has really flourished. And this was something that was really not captured in the original IOM envisioning of health literacy and links with education. The formal education system was well articulated, wanting us and asking us as a nation to work very closely with the K through 12 system, with the undergraduate system, with graduate and professional schools. But what really did flourish in a wonderful diversity of examples and experiences was the non-formal sector, where you had community education projects. Many of the projects are still in the gray literature. the avenue to publication is not quite as easy as it is with harder medical-oriented studies, but there's really a delightful array. There are professional continuing educations, online courses, but also courses in community as a result of so much of this effort. Sorry, I don't know exactly what I did, but there I am. Now, some people may ask, why is the progress slow? Or why is the progress not as complete as it could be? After all, our argument is very powerful. We have so much documented to show and to prove that health literacy is an important consideration, an important variable, that the link with disparities, the link with untoward health consequences has been made. What's happened? And I'd like to offer a bit of a theory-based analysis here, first starting with the concept itself. After all, if you're going to teach something, you have to know and be clear about the content of what you're going to be teaching. And as Nutbeam pointed out in the year 2000, health literacy is an evolving concept. And indeed, we have really changed the nature. Howard Koh spoke earlier really about a paradigm shift, but it's also a shift in our understanding of what constitutes health literacy, what it means, where the locus of responsibility is, what the content area is that we're going to supposedly teach about, whether it's teaching in formal or non-formal settings. It's only recently, I claim, that we jumped out of the box, and the box being confined with a myopic focus for a decade of the skills and deficits of patients. We've leapt out of that box, and we're starting to look more closely at the importance of materials. Not so much can patients access materials, but are materials accessible? We're looking more closely at the skills of health professionals. And again, health professionals, I'm not just referring to healthcare professionals, because I put my profession in public health and public health community on the table as well. And we have to look at our communication skills. And indeed, as so many speakers have pointed out this morning, we're starting to look at institutions, and not just institutional behaviors, the culture and the norms, the policies and practice in public health, in healthcare, and in truth, I should add social services as well, because that's very much an important part of health literacy, a much broader focus. So it's only when we pay attention to all of this that we benefit the patient, we benefit the individuals, we benefit the community. Now, a little bit of a theory-based analysis, I was hoping might also offer us some insights into understanding what's happening with health literacy and what has taken place over the last 10 years. I always turn to the grandfather of the social and behavioral sciences, Kurt Lewin's work, and we can get a lot of insights by applying Kurt Lewin's force field analysis. He asks us to pay attention first to analyze the current situation. And once we analyze the current situation, we can articulate our vision for change. Now, I will say something about the current situation, meaning back in 2002 to 2004, when the first report came out from the Institute of Medicine. Articulation of change really came in our listing of recommendations. These are the changes that we wanted to see. And the force field analysis that Lewin suggests is that we must identify very carefully the facilitating forces as well as identify the barriers, because only when we do that force field analysis can we develop a strategy for clearly moving ahead. So what was the context at the turn of the century? The context was a period of almost exhilaration in looking back. We were all so excited. Look at everything that was happening between the years of 2000 or maybe 1999 and the report that came out in 2004 from the Department of Education. Earmarking literacy amongst adults in the United States, from Health and Human Services, from NIH, from the National Library of Medicine, from the AMA, from AHRQ, from the IOM. This is not everyone. I didn't list, I ran out of space, but these are just some examples of what was happening. Our colleagues in Europe are absolutely amazed that the key players pushing this agenda forward with great excitement were government for the most part. Government players. Some of the luminaries are here in the room. You know, I look at Alice and I look at Marin, and thinking about the contributions. Cindy is back in the room. Cynthia Bauer is not here, but I think about the luminaries in government who really move this agenda forward, including moving the potential and the real possibility for funding forward. We look at the facilitating forces for the individual researchers. It was a new field. You could make your mark. The white papers and editorials that came out, the dedicated conferences counting in the hundreds, the workshops and presentation, and the incentives were very real for many people, forging a new career in this area. But what were the restraining forces? It was very disquieting. It was a challenge to norms and common practices. We were working with an overburdened system. Look at the arguments that people made and still make. There's just no time. There's no funds. There's no room for this. And there was a disquieting implicit critique of you're not doing a good job, you're not communicating well, you're not serving your community as well as you could. And people don't like to hear that. We too have been reticent in making critiques about, in a sense, the failures of health literacy. Ebola is a failure of health literacy. We haven't really publicized it in that way. There's a little focus on efficacious action. The 204 report really pointed that out, that the next step, saying this in 2004, was we really have to test out implementation studies and really delineate good action plans. We didn't quite do that, and there was a shifting focus of responsibility. In addition to restraining forces, there were constraining forces. The budget crisis, the cuts in sequestration, the example that I give, are the absolute devastating cuts to adult education, which had a marvelous beginning in integrating health literacy, and they're disappearing. Adult education programs are disappearing, losing 70% of their staff. Well-funded programs at the beginning have disappeared as well. So health literacy education programs for staff, whether it be at the CDC or Veterans Affairs, have not been funded for the implementation stages. The strategic action that Lewin calls for is not only to understand the current state, to identify your strategy, to remove barriers is the first issue. And could we have improved on our work over the past 10 years if we hadn't been just really giddy with the facilitating factors and had paid a little bit more attention to strategic action, identifying the restraining forces in some way? Another theory which gives us, I think, a great deal of insight is diffusion of innovation. And with diffusion of innovation, if we think about health literacy as an innovation, and we analyze it from that perspective, we get some great insight into perhaps why things didn't quite happen as well as they could have, but it gives us even more insight into what the next steps might be. And these are the core elements that one pays attention to in the diffusion model, the processes that are undertaken, the malleability of the innovation, the idea that you might have to re-articulate, change the innovation in some small ways to meet different audience needs, communication channels, and so forth. So health literacy as the innovation, the implications for practice, institutional concerns, material development, all of this is incorporated under this notion, this broad notion of health literacy. And when you analyze the innovation, you're paying attention to relative advantage, whether it's compatible with the existing norms and practices, whether you can try it out, how complex it is, whether it's observable. And some of these have a plus next to it and others have a minus. So it was a mixed bag of very positive elements and some difficult elements. Perhaps we could have paid more attention to some of those difficult elements and changed our approach a bit. Communication channels have been extraordinarily challenging. In medicine, it's a little bit better than in public health, for sure. but the myriad journals that speak to specific audiences. The idea, and George pointed this out, we have to repeat the same message over and over again. You have to repeat the same message over and over again in multiple journals, in multiple conferences, to multiple professional groups. We're a very vast audience and a very diverse audience. So the multiplicity of audiences, each with its own channel of communication, has made some of our lives turn into a roadshow, as though we're part of a rock band and we're presenting and we meet each other at different conferences, each of us giving a workshop, a talk here, a talk there. It's been exhausting in many ways. Time. We're all in a rush indeed, but one really needs to learn that lesson that time is an important factor and patience is very important for the saturation, for the knowledge to spread, for persuasion to take place, for decision-making and action to follow. So we're still at that point of persuasion in many instances. Key members, many of us who were beginning the health literacy work were outliers in some way. Some were very young professionals. They didn't have the gravitas or the weight that would allow people to listen to them with ease. Things have changed over time. We've gotten older. We perhaps have more gravitas to us, but that is an important factor to analyze as well. The social system and the characteristics of the social system is something that we're now addressing as we're beginning to look at characteristics of institutions, both in healthcare and in public health. So lessons from diffusion of innovation is you have to analyze the decision process. You have to look very carefully at all of the elements and perhaps consider a little bit more the reinvention and the malleability of health literacy, to adapt the innovation to fit the core needs of the member system. And that may be why we didn't resonate closely with education, because it seemed like an added burden, rather than to speak directly to the core needs and the core notion of educational systems, rather than add an additional burden. So for future planning, for strategic action, I would contend that doing a diffusion analysis and doing a force field analysis will help us move ahead with perhaps greater precision to move this field ahead. That's not to say, however, that we should not celebrate. Indeed, we should celebrate the accomplishments in health literacy education. Most of those accomplishments are really due to the fact that we had an incredibly supportive environment in our government agencies and institutions. Policy is often the last thing to change, and here people in government were driving this field in a absolutely magnificent way and funding the field in an absolutely magnificent way. And so the rich array of educational resources and programs that have long been and still are available for free online for health professionals, for institutions to adapt and adopt is very much there for us. Very much thanks to the hardworking people in our government institutions. Astonishing thing to really celebrate. So I rushed through those last 5 minutes with due speed. Thank you for your attention.